I'm the president of the IUSSP, Tom Legrand, calling in from Montreal where there is no electricity, so I'm on my cell phone. That's probably why I'm bouncing around in your image. I'm thrilled to welcome you to this webinar on quantifying COVID-19-related excess mortality in Latin America, demographic analyses of death registration data. This event is part of the IUSSP new webinars series, and most of the webinars so far have focused on aspects of COVID-19 pandemic. I want to mention the next webinar will take place on the 29th of July at about the same time on the topic of the pandemic's consequences for adolescents and youth. IUSSP members should have already received an invitation to register for this event, and non-members should keep their eyes on the IUSSP website for news of this and other upcoming webinars. I also want to let participants know that the IUSSP has set up a new webpage of resources and links on demographers' contributions to understanding COVID-19. This page was originally set up by Stefan Helleringer, who's one of the speakers today. Today's event is organized and run by Romesh Silva of the UNFPA, who is the chair of the IUSSP panel on population perspectives and demographic methods to strengthen civil registration and vital statistics systems. This is one of our most active panels. It's one of the 3 IUSSP panels that are heavily involved in work on innovations to population data and methods. With that, Romesh, I'll leave the stage to you.
Thanks so much, Tom, and welcome everybody from around the world. We're very excited to be hosting this webinar. I wanted to mention that, as Tom has said, this is a webinar sponsored by the IUSSP panel on population perspectives and demographic methods to strengthen CRVS systems. Please do take a look at the panel's webpage on the IUSSP website. We have a number of programs that we're working on. We have a fellowship program where we do some research mentoring of early career demographers and population scientists working on civil registration and vital statistics issues. And we're also working on Springer IUSSP edited volume and also a special journal issue coming out early next year. So please get in touch if you have ideas or suggestions for the panel, particularly as we head towards the International Population Conference in December 2021, which the panel hopes to be quite active in putting on some events. Today, we do encourage colleagues to post to social media about with questions and discussion and thoughts about excess mortality in Latin America due to COVID-19. We've listed a number of hashtags there, and the IUSSP and IDRC official Twitter handles. And that is a good segue to mention our excellent co-hosts and co-sponsors, the International Development Research Centre of Canada's Centre of Excellence on CRVS systems. The centre is a powerhouse when it comes to civil registration and vital statistics work, doing a lot of important things in terms of advancing global standards, developing new tools, collating research and practice materials, and supporting work all around the world, particularly tied to the Global Financing Facility on Reproductive Maternal Newborn Child and Adolescent Health. We've listed the websites, both of the Center of Excellence and particularly their resource library. I really want to encourage IUSSP members and demographers to take a look at it. It's a treasure trove of really interesting material, which helps us understand more about civil registration systems and potential entry points in ways that demographers can get more engaged in some of this work. A little bit about the format of today's proceedings. We're going to launch fairly quickly into the the presentation by Everton Lima. Everton's an assistant professor at the University of Campinas in Brazil, and he and his colleagues, their paper on excess mortality is really the focus of today's session. We're very, very fortunate also to have Jenny Garcia from INED, the French National Demographic Institute, and Stefan Elleringa from Johns Hopkins School of Public Health, who will be providing some discussant comments and reflections before we then move on to a moderated question and answer and comment session. And then to round out our proceedings, about 5 minutes before the 90-minute mark of our session today, we'll close out the Q&A session and hand the floor to Montasa Kamal. Montasa is the program lead on maternal and child health at IDRC and leads the Center of Excellence there. So we're very, very fortunate to have him with us to conclude today's proceedings. A little bit about the logistics of our session here. Please do use the Q&A function in the Zoom webinar to ask questions and post comments. We really encourage you to do this in real time throughout the presentation by Everton and also the discussant comments by Jenny and Stefan. And colleagues can vote with their thumb and endorse certain questions which they'd like to see engaged in the Q&A. So we will pay very, very close attention to questions and comments which get voted up, so that we'll give those priority in terms of the moderated Q&A. And do please, if the question is directed particularly to one person, please do type his or her name into the question so that it's clear. And yep, and we usually see a lot of questions and comments, so do scroll down and look through the questions and comments and vote so that we can guide the moderated Q&A accordingly. Excellent. So with that, I'm going to pass the mantle to Everton. Please, Everton, over to you.
Thanks, Ramesh, for the presentation. First of all, good morning, good afternoon, good day for everyone. I think you have people from all over the world. So here is morning, so in Paris and the places in Europe and Asia, it's late in the day, so good day. Well, I will share my screen first, and then I will start talking. Let's share screen. So I hope everyone is seeing my screen. I have a little bit confusing. There is a continuum button in the middle, which, okay, now let's go. There we go. So, sorry for that. Should be beginning. So, yes. So again, thank you everyone for being present for this talk. What I'm going to present to you guys is research that it's still going on, and it's in collaboration with a couple of friends from institutions in Brazil and also in surrounding countries in Latin America. So this is the pool of people that are collaborating with us in this research. So what I'm going to give a talk, it's about excess mortality in Latin America. And until now, we have a couple of select countries. And what I will discuss in these 25 minutes that I have is just a couple of topics that I just summarized here. So first I will describe why study excess mortality and this time of pandemic. That's the one of the first things that I will highlight. And then I will present to you the countries that we have so far collecting data and have done some analysis. I will also discuss about the data sources and the methods that we use. And then I will present some results, and I'll give a very few points of discussion, and that's it. So why study excess mortality? That's the first question that we can address here. And there are very important reasons about it that we can highlight why it's important to use this metric to analyze deaths and times of pandemics. So the first one, it's we don't have access until now for good data of COVID deaths. And I would say it's not only an issue in Latin America, but it can also be expanded to all of the world. So this is one point that make available this kind of analysis. Another thing is that the possibility of having cause of death data and also the time that these deaths could be recorded and make public available. It's also difficult during these times of pandemic and quarantine and so on. So what we think is that if you look at the overall mortality levels for some specific areas, we can talk about countries, or we can talk about subnational areas, in different points of time, this could be a way that can provide some information about how is the COVID deaths is affecting mortality. And that also can serve as a way to orient public health policies and so on. So this are some reasons that we can highlight. And the main question that we can ask for that is what could be the number of deaths if there was no COVID? And then how can we answer that question? And then we can look at the excess mortality. Okay, this is one way. So we look at the number of deaths in the current year comparing to the same period, the same monthly time of deaths in previous years. This is one way. So we're just comparing what we have collecting of what we have seen of deaths, total deaths, just right now, and comparing with the same months, but in previous years. And then we can estimate different kinds of measures, for example, ratios of deaths from one year to another. And this particular study, we have tried different other kind of measures. We estimate averages and differences of percentage and so on. I will talk more further when we get there. There's also a couple of studies and data that I'm showing here. There are much more. I'm sorry that I could not provide all of them, but that already have done some analysis on excess mortality. In Brazil, specifically, there are a lot of studies already have, some of studies have popped up and showed excess mortality in cities and for a couple of months, I think to May or June. There is still some studies coming up. There are also some data sets that are collecting total mortality. Here I'm showing some of those. And so this is one also good reason that we did this approach. We follow these studies and we went a little bit deeper. And another thing that we should also highlight is that there's a lot of misinformation also concerning excess mortality. I'm just showing you here one news that we got a couple of days ago. And it says here, Brazil has 0 excess mortality in June. So how can we trust that? Is that true? And so that's why it's important to do this kind of analysis and see how the best way to approach it, this information and so on, so that we can give a better prospect of how the pandemic is hitting and how the pandemic is affecting the levels of mortality in our population. Another thing is that we also needed to take to account is that not all excess mortality happened due to COVID. And there are some discussions about it, like Neumann and Hellinger said, there are 4 different ways that we can understand COVID in terms of mortality. So they presented 4 different points. One is the direct mortality. So that's the mortality that's recorded as COVID deaths. That's the one that we got from vital statistics and civil registration systems. The other one is the direct and indirect effect, I would say. And that's that there are deaths that were COVID, but were not resisted as such. And then there's the indirect death. And these ones are the ones that there were other causes of death, that people have died, but because of the health system was affected by the pandemic. So overcrowded health system. So the person have died from another cause in particular, but due to the pandemic, they didn't have access to the health care. Another way is also COVID is now, we can consider a competing risk. So it's another kind of death that are competing with other causes. So we need to take into account these 4 points before we analyze excess mortality. Latin America, why Latin America? And that's, Latin America is now the epicenter of, considered the epicenter of the disease. We have seen, if we look at some data from Johns Hopkins, for instance, they are showing Brazil is now the 2nd country, and then some of other Latin American countries like Peru, Mexico, they are also increasing a lot in numbers of infected. So this is one reason. The other one is that mortality data, I already have mentioned it, of COVID is very underreported. And in Brazil, if we also, or other Latin American countries, if we talk about it, mortality registration, there's also this issue of reporting, misreporting. Latin America is also one of the regions of the world where the tests rates are the lowest ones. And there's also delays between the tests, effective tests, and the time that the results are released. So all these issues make Latin America a very interesting place to look at right now, and to see how this pandemic is affecting our mortality in this region. So which countries we analyzed? Well, until now we have 4 countries. Mexico is also underway, I will mention at the end. So Brazil, Chile, Ecuador, and Peru are the countries that we are doing analysis right now. Why Brazil? Brazil was, I think, one of the first also countries that present cases of COVID in the region. And probably many people are familiar with the famous phrase by our president who said that the virus is just a little dose of flu. So in other words, we didn't have, after the beginning of the pandemic, we didn't have a well-coordinated process to tackle this disease. So it started to spread really fast. Peru, the country also started a lockdown in 15 March, but despite that, now we're seeing a fast and growing number of deaths by COVID. Ecuador, the mortality explosion in Ecuador, it started in the months, between the months March and April, and it started on the coast side of the country. I think the province of Guaya, there's a port, the port of Guayaquil. So the pandemic of the mortality started to increase in that area and then gradually moved to the rest of the country. And the case of Chile is also interesting, that the country didn't opt to first to apply a full quarantine, and the choices that they had was to adopt a high number of daily tests with what they call it dynamic quarantines. So this is how the pandemic hits these countries and what they have done to try to stop it. And in common, I would say that in the 4 countries, the strategies adopted seem not to work. And then what we saw was, as a result, is that the number of deaths and the number of infected increased a lot. And that's, again, one of the reasons that we are trying to look at the impact of this disease on the mortality. We're looking, so again, as the excess mortality in the year 2000, and we compare it with the relative mortality in the previous years. 2019 for 3 countries, and only in the case of Ecuador, 2019 and 18. What about the data? Which I think would be I will get a lot of questions about it. For Brazil, we use this new, this is an online portal. It calls Transparency Portal, which has, it's a kind of administrative record. This is, just to highlight, this is not data from the Ministry of Health, and that is also not related to National Statistical Office, but this is a data that we have access now. It's online, and it has data from 2016, I think, until 2020, monthly data for almost all municipalities of the country. And we have collected that using some tools of data scraping. In the case of Ecuador, we also have collected monthly deaths from civil registers for years 2018 until 2020, and this is also available in this web page. In the case of Peru, the data is also public available, and it's organized by the Ministry of Health. Under request, you can get access to this data, and it's also monthly. We have by districts. I think this is the smallest area that we can go, but one of my colleagues can probably later say something. In the case of Chile, we have that counts data, which was compiling. I say here data scraping, but we tried, it didn't work out. So at the end, we needed to type manually this data. And it's on the web page of this Tableau Public, which from as far as I read, it's combined work between the Ministry of Health and the Statistical Offices of Chile. So what are the methods? So we have looked at the mortality levels from March to May in all countries from 2020, 2019, and sometimes 2018. This is the case of Ecuador. Why March as a country, as a month, as the baseline month? The reason is that most of the countries that we have searched, the pandemic started at the end of February, beginning March. So we thought probably the best comparison time would be if we have as a baseline month, March, which was the time that pandemic really hits all these countries that we have so far. And then we look at that and the months afterwards. The analysis was in small areas. For some countries, we have municipality levels, like Brazil. Peru is districts. It's a micro data. For Chile and Ecuador, we have departments, which are kind of provinces. They're small, but they're a combination of municipalities. And we estimate 3 measures for looking at the levels of mortality. The first one was the average of deaths in these 3 months, March, May, April, 2020, and the previous years. And then coefficients of variations to see how these deaths are homogeneous or heterogeneous in all these places. And we also have estimated percentage differences in total deaths between these 2 periods. This is one very important point that I'm already making clear. We didn't do any kind of quality test, so we are aware of the limitation of the data. And there are many issues that we can discuss about underreporting, delays of reporting, variation in quality of information, variation in under-registration. So all these issues, for sure, they are touching the data, and we need to take into considerations, which for sure it's a limitation in our analysis. So we didn't, to make it clear again, we didn't apply any adjustment to the data, just take crude data for the analysis. So jumping to the finds, I think I'm almost there. What do we have for Brazil? In Brazil, I'm just showing here a couple of metropolitan areas. Okay, we have all the data for all municipalities, but we just showing some metropolitan areas that we choose to the best, also for the graph. And then we have here the capital of the metropolitan area, and the other municipalities surrounds the metropolitan area without it, the capital. And what do we see? So there is a line here on 0, which says this, that's the percentage differences between 2019 and 2020. So everything after 0 means increasing that. And all the metropolitan areas that we have searched, at least in this graph, we see increasing in percentage of deaths. And the first hit is the pink points are in the capitals, so are the major cities. But we also see some cases where the most increase is seen in the cities surrounding the capital of the metropolitan area, as the case of São Luís here, the second metropolitan area in this graph. Another nice way to show it is to look at the average deaths and the coefficient of variation. So the first graph, we just have the same 6 areas, the same municipalities, and we're showing here how is the average deaths increasing between these 2 years. If we look at the average deaths, we see that mostly the high numbers are seen in capital and the big cities like São Paulo and Rio. They are the ones where the deaths increased the most between 2020 and 2019 in these months of March to May. But if you look at the coefficient of variation, and then the picture just it's another way around. Cities like Manaus, which is in Amazon region, São Luís, Fortaleza, all these other cities which are located in the northeast of the country, they have a much higher coefficient of variation in terms of mortality between these 2 years, which could mean many possibilities here. So I summarize the results. For Brazil, the average mortality was higher first in the major cities. They are the first cities who get in contact with the disease, like Rio and São Paulo. But the coefficient of variation shows much more heterogeneity of deaths in cities located at the north and northeast of the country. This could mean many things. We also think that this increasing number of, there is also increasing number of other cities indicated also that the deaths are moving to the inland of the country. And that's also what we're seeing right now. What about Ecuador? Ecuador, first, we see a very cluster of excess mortality on the coast of the country. So Guaya is somewhere here, which is the place where I think the mortality hits harder. And on the right side, we see the curves of excess mortality, and all this, it's red, okay? The red ones are the 2020. And what we see, of course, we didn't have finished yet. The data for June, probably there are still some corrections and so on. But what we see, what is interesting now. So from the map to here map, we see that mortality hits harder on the coast. But from the graphs on the right side, we see this region of Pichincha, where the capital, Quito, is located. And we see that there is steadily increasing mortality. So probably the mortality is moving in the country as we saw in Brazil. So I already said that. I will jump to another country. What about Peru? Peru, and then we have also here two graphs. On the left side, we have the departments of Peru. And here we have average mortality, that's the first, and then excess mortality and coefficient of variations for the departments. On the right side, we have the districts of Lima and Callao, where we also try to look at the spatial patterns of mortality more in areas less populated. So there is clear cluster and a pattern of mortality in both maps. And I'll summarize more or less here. So also in Peru, the overall percentage of variation mortality increase is about almost 64% more mortality in 2020 than in 2019. And that's for the entire country. The number of excess of deaths was not uniform spread. That's one find that we have. And also, if we look at the more disaggregated analysis, we see that now in this stage, the most affected areas are the districts less developed of Lima. And what about Chile? And also in Chile, we see very clear clusters of deaths. If we look at the average, there are some mostly in the center of Santiago and surrounding comunas. Comunas are municipalities, but also they are spreading through other comunas more outside the metropolitan area. And this is another graph where it shows how much is the increase in percentage mortality between 2019 and 2020. So just to highlight more about these effects. So in Chile, we also see the excess mortality is observed as in many other places in major cities, but it's also spreading at surrounding areas of more distant and surrounding areas of the capital. So what do we have for discussion? And then I'm close for today. So there is increased mortality observed, and that's, I would say, common in almost all countries of the region. Certain cases, the excess mortality reaches values of 200% more mortality in 2020 than in 2019. Also, the pandemic of the mortality started to hit first in the more developed urbanized regions of each of those countries, but we also see that it's gradually moving to the inland. And another thing, which is also verified by our data, is that it's also affecting less developed areas more and more. That's why I put it here, probably a second phase of the pandemic. So what we have, and that's probably the future for this work, we are now working with the data from Mexico that we got from a friend, and we are also doing more work on that. And in the case of Brazil and also the other countries, I would say, we are trying to update the death information, and if it's possible, to add more regions to the analysis. So that's it. I thank you. Obrigado, gracias, and merci. And if you want to have access to the paper, we have a preprint, which is, here's the link. I just updated because we did it yesterday. And that's it. Thank you, everyone.
Thanks so much, Everton. Excellent, right on time. So let's move quickly to our first discussant, Jenny Garcia from INED. Please, Jenny, you have the floor.
Okay, good afternoon, good day, everyone. I would like to thank the panel for the invitation to this discussion. I will share the screen in a moment. Okay. Oh. Is this one? Yeah. Okay. Yes. Sorry. Well, I will focus my comments on the limitations found when analyzing COVID death counts in Latin America, the obstacles overcame by Lima and colleagues, and the remaining challenge to this data. So, what are the essential issues when we need to address when analyzing COVID data? I will use Brazil and Ecuador published COVID death counts in order to illustrate some of these issues. Brazilian COVID death counts come from the civil registry and the Ecuadorian from the Ministry of Health. And well, the first key issue is the date of reference used when counting the deaths. To each death, a date of occurrence, registration, and publication could be attached. The time difference in these three steps can severely affect our assessment of the stage of the pandemic. In Brazilian case, we can have access to the street date at national levels, while in Ecuador, it's not clear if the date of reference corresponds to the occurrence or to the report of the death. The second issue is the differential introduced by the place of death coverage. COVID data in Ecuador is collected exclusively in healthcare facilities, and deaths occur at home are missing from the report. This is important because in Ecuador, around 46% of reported deaths in previous years occur at homes. In Brasilia, data contains deaths occur in all places. However, as of today, around 95% of reported COVID deaths have occurred in hospitals. The third issue is regarding the COVID definition. Deaths are attributed to COVID as the result of a positive test or a clinical diagnosis. Patients who die in hospitals are usually tested, but death at home can be qualified in various ways. In Ecuador, confirmed cases are those with positive COVID test, while a reported category of probable cases is defined as cases for which the test was inconclusive or not applied, given that a contact with a positive case was traced or symptoms were recorded. Reported death of probable cases during April in Ecuador outnumbered confirmed ones. The fourth issue is the magnitude and the dynamic considered for analyzing the geographical extent of the crisis. Daily and cumulative COVID deaths are particularly valuable for understanding the dynamic of the epidemic and what is its tempo. In Brazil, daily cumulative death counts are available, while in Ecuador, cumulative death counts at the subnational level are published with irregular periodicity. Daily death curves are highly fluctuating. These variations are mostly likely the result of information feedback. In this sense, it is necessary to split the effect of the information feedback from the pandemic trend, because recording times can vary among regions within the same country or even according to the place of death, if the death occurred in the hospital or at home. The fifth issue comes from subpopulation disparities. Given the vulnerability of older people to the virus, the age structure of population, the existence of age-biased reporting patterns, and the geographical distribution of healthcare facility play important roles in the number of deaths reported. In Ecuador, for example, 70% of total deaths occurred at home during previous years, were on population 60 years old and over. Consequently, a younger mortality structure is seen on deaths occurred in healthcare facilities in comparison to the mortality structure of total deaths occurred. These difficulties of quantifying how much of the excess mortality can be directly linked to COVID are enormous and diverse in kind. The authors have overcome most of these obstacles by offering an overview of the direct and indirect impact of COVID through the analysis of excess mortality. With their approach, the global impact of COVID-19 death could be measured avoiding problems with COVID definition and confirmation, the under-registration coming from limited number of tests per capita, and focalized testing strategies. The different coverage in COVID-19 death counts linked to the place of death was also overcome. In addition, by contrasting the evolution of death in each subnational area separately, they also get rid of the bias introduced by spatial differences in the coverage of civil registration systems. However, assessing a spatial difference in the pandemic implies the consideration of other issues too. So, for example, the effect of the variability of the registration time lag among subpopulation areas, subnational areas, sorry. In this sense, particular attention must be given to the time in which data collection is carried on, and the exact date of the data collection must be clarified. This is because reported data for the same period could significantly vary from one report to the other. In the graph, I am showing to you all causes of death data coming from civil registration in Ecuador. I took the reports corresponding to June 30th as the most complete one. This is my assumption. And I estimate the proportion of reported death included in previous report from the month of March to June. Guayas province, the main hotspot of the pandemic in Ecuador, is in the right side, and Ecuador in the left. Percentage are illustrated by colors, from purple as the most complete data to yellow, the most incomplete one. Cases occur and report in April 30 represent less than 70% of total deaths occur in April in Ecuador, and around 75% in Guayas. This delay in the registration time lag affects the proportional distribution of cases among subnational areas. For example, in the report published on April 30, Guaya concentrates 69% of occurrence death in Ecuador in April 2020. While in the report published on June 30, they represent 60%. The same deaths occur in April. This result is an indication of larger time lag in registration in other provinces in comparison to Guayas. In this simple example, the 90% cases that could be attributable to the spread of the pandemic to other areas come from spatial differential delays on data publication. Another element introduced bias on the estimate may come from the accurate declaration of the place of residency of the disease and the place of occurrence of the death. These two variables could be mistaken in the death certificate during the ongoing crisis, as well as a highly influenced by geographical distribution of healthcare resources and internal migration. I would like to finish by congratulating Lima and colleagues for their great paper and question them on how this challenge could be addressed in the countries under analysis. Thank you for your attention.
Thanks so much, Jenny. We'll move straight to Stefan Elleringer for the next set of discussant comments. Thank you, Stefan.
Okay, good morning, good afternoon, everyone, and thanks for the opportunity to comment on this very interesting paper. So just briefly a few remarks. First, to recall why we measure excess mortality. So as was mentioned, that's a measure that seeks to address some gaps and limitations in hospital records that are reported daily in most countries, hospital records of cases and deaths, because those records of cases and deaths suffer from various issues that are well known by now, including undercounting of cases and deaths due to limited testing. As was reminded us, testing is especially limited in several of these Latin American countries. Omission of deaths that occur at home, including due to COVID, and we very often encourage people to stay home when they have suspicion of COVID. So some portion of the death may occur in that setting and outside of health facilities. Deaths may also occur in other structures, for example, long-term care facilities, and at least early in the pandemic, these deaths weren't counted in the daily tallies of deaths due to COVID-19. Also, one gap has to do with the indirect deaths that are due to the pandemic because of disrupted health services, economic downturns, mental health consequences. So these are a range of potential deaths from causes other than COVID-19, but that still need to be counted towards the death toll of the pandemic, because if the pandemic hadn't happened, they likely would not have happened. And so calculating this excess mortality helps address some of these gaps, and it requires data from death records collected via the vital registration system to be able to track this on a continuous basis during the course of the pandemic. Okay, so the paper by Lima and colleagues, I thought, was a very ambitious review of available data on mortality in several countries in Latin America, which, as we were reminded, has now become a real epicenter of the pandemic in terms of its spread and its effects on mortality. And the paper documents large increases in all-cause mortality in 2020 relative to 2019 or 2018 in several of these, in many localities in the countries that are considered. So it's notable also that the data that were presented were up to the end of May, so prior to further increases in spread in some countries, particularly in Brazil. And one thing, in addition to what Jenny already pointed out, I would like to congratulate the authors, I think, for a fascinating look at subnational data in the context of excess mortality, in particular because they didn't follow the traditional administrative boundaries that we use that are looked at in reporting excess mortality. So very often we have estimates of excess mortality by broad administrative classification, so district, region, department in the Francophone countries, for example. Whereas here they looked at more detailed patterns of spread between metropolis and smaller or more less urbanized areas within a particular administrative unit. And I thought that was particularly informative, at least in the case of Brazil. So a few issues of discussion. One, as you imagine, has to do with data issues, and several things that I would like to raise in that context. So the first one, has been pointed out by the authors and by the first discussant, has to do with the coverage and timeliness of death registration during the course of the pandemic. So does it, being able to measure excess mortality and measure excess mortality in a precise and unbiased way depends on the coverage of death registration. So first it must be high, obviously, but also it must be constant, or it must be known in a way that we can account for it in the analysis, because some variation in the counts of death that we observe in locality might have to do with the ability of the system to actually count those deaths. So it might be, for example, in one way that the coverage of death registration goes down during a pandemic due to disruption to administrative services. Imagine the people who work in those services get affected by the pandemic itself, and there's a higher absence at work, for example, than there was in the past, or some places of registration have to close. Or on the other hand, they get overwhelmed by the need for registering new events. On the other hand, we can also imagine that coverage improves because there's increased attention that's paid to death. There are systems in place that are put in place to record COVID deaths. We start counting death in settings that are unusual, and so on and so forth. So all this is a potential confounder that needs to be accounted for in some way, and I would like to hear from the authors about their thoughts on that. Also, one thing that doesn't get much discussed in terms of the measuring excess mortality is the population at risk. So the count of deaths that we are able to see through vital registration originates from a population that has a certain size and a certain age structure. And during the course of the pandemic, that may change because of various modifications to migration or mobility behaviors, whether they're related to lockdowns, for example, and restrictions on mobility, or whether they might be related to changing behaviors to look for economic opportunity in time of lockdown. So, for example, it might be that people move back to rural areas because there's more social support in rural areas through extended kinship and various things like this. So this may also prompt a trend in the number of deaths that we observe that needs to be accounted for. And same, for example, for the place of death. If there are restrictions on transportation of bodies following a death, for example, if we can't transport bodies to place of origin, for example, or village of family residence, for example, to conduct the burial, that may affect this. And it's especially relevant, I thought, when looking at subnational data, as was done in that paper. So continuing on data issues, I'm wondering if in Latin America there are prospects for lobbying to release more vital registration data, maybe faster, whether it concerns age at death, some elements of cause of death that may be released faster, whether there is a mention of COVID-19 on death certificates, the type of data that has been used, for example, in the UK or other European countries to try and understand the mortality impact of COVID better. And in supplementing some of these analysis, I'm also wondering if there might be a use for data generated by mobile phone records or Facebook usage to try and provide a more accurate assessment of the population at risk of death and try to control for this potential confounder in the analysis of excess mortality. Second aspect I think that warrants a bit of thinking or reflection is whether these measures of excess mortality that have been looked at a lot recently help guide the response to the pandemic. So one first question that comes to mind is since excess mortality is designed in a way to fill gaps of the existing reports of cases and deaths, well, does this allow detecting previously unknown clusters, so or areas where we didn't know the virus was spreading as extensively, or had an impact on mortality? So in that regard, it might be interesting, since you have data now on a very disaggregated spatial level, to try and conduct some sort of systematic comparison with data reported from hospital systems and other sources to try and see if there are indeed such areas where we detect impact that is not visible from other systems. Then another question is whether this helps us measure, this helps us target the response and or allocate the resources better. And I think here a key aspect is whether, based on the data from the vital registration that become available, we are able to get a sense of the direct effects of COVID, of the pandemic spreading and causing deaths directly, versus its indirect effect through disruption of health systems and economic downturns and so on and so forth. That might be that this is something different age patterns of excess mortality might help us look at, but it would be interesting to think about that a little bit more. And finally is whether we can use this measure to evaluate the response itself to the pandemic. So does do interventions put in place by health authorities, NGOs, and so on and so forth save lives in the end? And complications that might arise here is that these interventions will unfold over time, and over time the age of cases changes, as seems to be the case, for example, in the US at this time. So that might affect the number of deaths that we see. Something Jenny was talking about also, the time lag between the various events along the line from infection to death to registration to reporting. Does this preclude our ability to use excess mortality to guide the response? And I will stop here in terms of my remark, and not until I congratulate the authors on their paper.
Thanks so much, Stefan. Very, very helpful. Let's turn back to Everton and his co-authors and give them about 4 or 5 minutes to respond to a number of the very thoughtful pieces of feedback from Jenny and Stefan. And before we open up to the floor, and I see there's already 21 questions and comments posed in the chat window. There's plenty of time for more, so please keep the chats and the thumbs up going in the chat window. Over to you, Everton, for 4 or 5 minutes of reply with your co-authors.
Okay, I thank you, Jenny and Stefan, for the valuable comment. Actually, there are many good suggestions, I would say, that I was reading this morning and say, oh, that's a lot of stuff that we can think about it. But to be honest, some of the issues I would just go through. I asked Paul to put my colleagues, 3 colleagues, so if they want to jump in and say something anytime, Bernardo, Andres, and Mario. So if they want to say something specific about their country, so feel free to do it. What I would say, one good point, and first about Jenny, say something about, and it's about the timing of the data collection. And that's one issue that we have been discussing. That's why we have stopped the analysis in May and went all the way through June, for instance, because we know the data that we are using are from, I will not call it unofficial, but it's a data that has some delays on specific for Brazil, has some delays on make it public available, this portal of transparency. And when I was reading also about the other countries like Chile, this tableau of something, they also say, look, this data is always up to date. So if you want to use it, you needed to go, I mean, you need to have that in mind. So the time of collection and the time that we are analyzing it for sure. And that's a good picture that you do when you have the province of Guaya and then you have the whole Ecuador and you show the differences in coverage when the timing is passing through. So this is something for sure that we needed to take into account, and I really appreciate this comment. Another comment from Jenny, which also falls in the same line with Stefan, is about the differences of coverage of those areas. And like I said, we didn't take that to account. I mean, we could not analyze that, but we know that there are many studies about it for Peru. Bernardo has done something with Mario, and probably they can say something more. That also we have done something about Brazil, that the underreporting varies with regions, regions with less socioeconomic advanced, they have problems, less developed areas have more problems with underreporting. So we didn't take that to account. This is something that we need for sure discuss more in the paper. But the one good point that both took is about the differences of place of residence and place of occurrence. And the case of Brazil, I think the data that we have public now, it's based on place of occurrence. So for sure, it has a lot of noises and problems, and especially if you go more deeply and disaggregated. So this is one thing. I think the only data that we have for place of residence is for Peru. Mario can say something if he's around. This is one point that both raised. Another thing is about the migration and mobility. Well, that's a tough one, I would say, Stefan. Well, for sure, if you go disaggregate and we go deeper in small areas, migration could play a role. We just don't know how that would affect, because if you are in lockdown, isolated, so we would not expect migration hitting. But at the same time, we're seeing that the pandemic is spreading. So probably people are moving around. So this is something that I was thinking about it. And for sure, we needed to, I would say more clear, we needed to put more in discussion in the paper. One question that you raised about releasing data more faster. Well, that's something that we would like to have. And the data from the Minister of Health, they are collecting, but they take a lot of time to make public available. And there are some, I would say, alternative data that we're getting, like this portal of which it's not, I would say it's not connected to the Minister of Health, it's not connected to the National Statistical Office. They are notaries, so they are collecting that. There are delays, and that's what Jenny said. There are delays and at the time when they collect, they receiving some notaries are not getting, for example, information of that. So for sure that will also affect the results in some sense. So this is something that we also wish to have faster official data available. Also break down by age and cause, which it's something that we are pushing. And there are some data already available also in these alternative portals. The Fiocruz in Brazil, for instance, they have done wonderful work. and publish, but mostly on COVID. So there are some countries you have by like Peru, microdata, you have breakdown by age. Calls, this is problematic, which will also be desirable for analysis, I would say. And your provocations about how this analysis could be a guide for public health. Well, this is something that, I hope it will, because like I saw in the presentation we have now, people are doing some analysis like comparing June, this June of 2020 with June of 2019, and saying we have 0 excess deaths. And due to these things that you guys already listed about delays and so on, we could not say that. We need to be more careful and we need to be more precise and in terms of analyze these kind of things. So we hope that that could be at least something that gives a lead for, but I don't know, Bernardo, if Andres, I see they are around, if they want to say something, I'll leave to you too.
Bernardo, Andrea, do you want to jump in, or shall we go to the moderated Q&A?
Hey, I'm Andres. Do you hear me?
We hear you loud and clear, Andres. Please go ahead.
Okay, sorry, I'm at the university, so I have to wear my mask. I think the case of Ecuador, we have to consider a lot of things. The first one is that the mortality registration system in Ecuador already has many failures in completeness and quality and timeliness, and that the data we're using, it's not the official validated data from the National Institute of Statistics, but the one from the registration office. And there are also a lot of geographical variations in data among provinces, data quality and completeness too. And what we can infer is that we're seeing a huge excess mortality in many of the provinces, especially in the coastal region, but that this could be undercounted or under-registered. So it could be a lot greater, and we have to consider this. It's on the limitations of the study, and I think what we could observe could be even higher. And other thing regarding the usefulness for public health, I come from the public health world, and in our context where testing has been really limited and where the reporting of COVID cases has been really limited, excess mortality data has been our primary source of seeing the evolution of the pandemic. I have a good friend that says we're letting the death talk to us instead of the cases talk to us. And I think that is really true. We can see clearly in the mortality data how the pandemic has gone from the coastal region to the Andean region and the Amazon basin. So I think it's really useful. It's an important first exploration, and we need to keep exploring this data and keep analyzing, taking into account the deficiencies. You mentioned migration, but also trying to see what we can do about this completeness of the data, and also about the indirect mortality, non-COVID related. We were seeing, we have in Pichincha, my province, we have now more than 1 month of saturated health services, and we're seeing a huge increase in mortality from chronic illnesses. So in the future, that's worth exploring how this affects the lack of healthcare services, and medication has affected people with other illnesses. Thank you very much, and congratulations to Everton. It has been a great presentation.
Thanks so much, Andres. Very, very helpful comments. I want to turn to the Q&A window. We have 26 interventions, and I think we only have about 15 or 20 minutes left to really engage them. I've been in touch with, let's take a first round of the top 3 questions. One is from Diego Iturralde from Statistics South Africa, Susanna Cavanahi from Brazil, and there's one from myself. I guess I'm popular today. Thanks for voting. Diego and Susanna have mentioned in the chat to me that it's okay to paraphrase their questions in the interest of time. So let's start with Diego's. He talks about how in times of lockdown, the mortality pattern in terms of cause of death may change, and in addition to there may be actually some reduction in certain causes of death. And I think we see this, for example, during times of lockdown with regard to things like road traffic accidents. And so Diego's question, which actually relates to another question in the chat window by Priscilla Mulacheri, is a lot about the choice of baseline. And I think there's a number of comments in the chat window about this in terms of how best to choose the baseline to compare excess mortality, particularly when there are issues of changes in the mortality cause of death structure. And then there's also seasonality issues. And I think some other people have commented about, well, you know, what's the correct reference when thinking about excess mortality? Should it be the preceding month? Should it be the relevant month from a previous year, or some kind of weighted average, or something like that? So that's the first question from Diego in South Africa. The second question was my own, and I was just recalling some excellent work by Andres Peralta, who was just on the line with us from Ecuador, his paper in 2019 and a paper by Helena Castañeda Cruz this year, which really identify notable sex differentials in death registration completeness in Ecuador and Peru, respectively. And they note that this sex differential in death registration completeness for these two countries varies markedly across geographic space in these two places. And so my question here was, how might we better understand the sex-specific and gendered mortality consequences of COVID-19 excess deaths, given that there really is, you know, substantial differences in access and visibility in death registration systems for men versus women. The third question was from Susanna Cavanahi, and somewhat related in terms of variation. She asks a lot about whether how registration, the probability of having a death registered may vary during times of COVID. And she asks about how that is playing out and how to incorporate that in the analysis. Yeah, and she also mentions that she asks whether there may be some increased registration of deaths in the chat window, which kind of postulate the reverse, which is, you know, during times of lockdown in response to COVID-19, are we seeing increased delays or increased under-registration in deaths in some of these places? And how should we account for that?
Well, I guess we missed Romesh. Does someone else want to continue? One of the panelists or one of your co-authors?
Yeah, I think we can jump in and say some very briefly. We try to touch some of the questions. One of Diego, who talked about the pattern of changing cause mortality during pandemic, and it's a valuable issue. Of course, we don't touch that because we are using total deaths. In the paper we do mention something about it, that we need to be careful with the results in terms of some causes of death may decrease. For instance, like violence, homicides, and the first times of isolation. But at the same time, the other kind of deaths could increase. For instance, feminicide. Since people are more isolated, so there are some initiated researches on that violence against women and the household during the time of quarantine. So external causes for sure will be affected. So we mentioned something on the paper. What about the baseline? Again, I think we did say something about, we started in March and we stopped in May. We didn't went further due to this lag. I think it's more or less the same question that I think Susanna proposed. It's why, and also the variation of coverage, how this is taken into account. And again, like Andreas mentioned it, for sure there is spatial variation. Regions that are more affected now. And that's one good trick, and that I would say. Consider even with under registration, we still see excess of mortality, right? Even in areas that, like I just showed you the case of the districts of Peru are the most poor ones that are now affected by, and are also the areas which we would say they have history of problems with data quality. So it's still like Andreas mentioned, and I think it's a good point. That's a tool, and I think everyone agrees about it. It's a tool to show that probably these numbers will be higher if we count it better. I'm not so sure. I read something about if now in times of pressure, the statistical office and all the Minister of Health, they are doing a better job and resisting things. I'm not so sure about this, and in fact, so. But there are some comparisons. For instance, Thomas from Fujiwara, he did a very interesting thing, comparing data from this data that we use for Brazil, for example, with, and then he fixed the trend with the vital statistics, the official ones that we have. So there are some things on this line. And what about the increase of delays? This is for sure one thing that we need to take into account. Also, a lot of deaths in the household could happen, which also increases the delays. And but increases registration, that I'm not so sure, I would say. One topic that's from Romesh's point about the gender sex mortality, and in terms of coverage, again, we also have me and Bernardo have a paper about Brazil, and we also analyzed regional mortality coverage in small areas of the country. And there's for sure a current point. Usually males are better resisted. Deaths of males are better resisted than females. It has to do with external causes and so on. But how is this happening in this kind of context? I was reading for Brazil and all the countries that we analyze, I will tell you, I don't know. But I was reading something today on Twitter that Jose Manuel posted, Aburto, he's now in Oxford, and they did a very interesting analysis on sexual differentials during pandemic, Wales and England, I think. And they see that actually the gap is increasing and not decreasing during the pandemic. At least that's what they found. So more or less is that. I don't know if Bernardo or Mario want to say something else. I'll leave the floor.
Thanks. Let me invite Bernardo and Andres to supplement.
Okay, no, thank you for having the presentation. We use the Registro Civil data that has some issues of delay, and there's a huge variation across regions. So there's some reports that legally they are supposed to inform this data within a week, and there are some reports that they are taking about a month. And also the question raised by Susanna that there's several protocols because of the COVID death and to the burials and everything, but there's some reports that they wait. There's a long time between the death and the final the final death certificate, because they're still investigating if the cause of death was by COVID. And it's mainly due to the lack of tests. So Minas Gerais, my state, so if you look at the data across the world, Brazil is one of the countries with the least number of tests, and Minas Gerais, where I'm from, is one of the worst in the country. So we don't test. And so this is a big issue. You read all the time people having to wait a long time to have the final death certificate that informs if it was COVID or not. And so there's some issues like that, and some areas of the country with really long time between the event and when they inform they put in the data into the system. So this is a big issue. And we found this, and I think it's common everywhere. And we found this in the case of Brazil, looking at only COVID deaths. There are much more women with a case. So it's about 90 males for 100 females. But when we look at the death counts, it's about 150 males per 100 females. So and this is very homogeneous across the country. So it's very, but yeah, and I thought that some questions on the cause of death, but this will take a while, and that's why we stopped 2 weeks ago instead of looking at the news article that Everton posted. They look at the same day. So they compare 2019 today with 2020 today. So 2019, it's okay. And then when they look at 2020 at this date, then you see for some areas, there's much less deaths in 2020 than 2019, if you look at the same day. So some places like 30% less. And some people, they're going around saying, see, there's not a problem. There's less deaths in 2020 than 2019. So this is getting like, yeah, it's quite dangerous to have this type of misinformation going around.
Thanks so much, Bernardo. Andres, we're a little short on time, but do you have like a quick intervention in 1 minute? Or should we go to a few more questions? Okay, I think maybe we'll go to a few more questions then. Just very quickly, since we do want to save time to Tassa's closing remarks, I think one thing which has come up in the discussion a little bit, and maybe I'll take the chair's privilege to kind of bring this to the forefront, is I think that there's differences in how responsive the health system and the civil registration system itself is to actually documenting the mortality impact of COVID-19. And I was wondering, Everton, Bernardo, Andres, whether you could speak to that a little bit. You know, we know from the policy side that there are some countries that have declared civil registration of an essential service of the government. And there are others that have not. And there are some which have done a bit of an in-between kind of policy announcement where death registration is considered essential, but marriage registration, for example, is suspended. So it'd be helpful to hear a little bit about how, you know, if there's variation there, both at the sort of high level government policy level, but then also the capacity of local civil registration authorities to actually document and register these deaths, given that what we're talking about is a highly clustered infectious disease mortality phenomenon. And then I just want to give a special shout out to some of the comments around migration and mobility during times of COVID-19. Our colleague Ellen Crowley, the chair of the IOSSP scientific panel on migration, has posted some comments there, and she's particularly interested in inputs and ideas about demographic analysis and analysis of the relationships between the pandemic and migration. Stefan pointed out some ideas around big data and Facebook and Twitter type information. It'd be interesting to hear a little bit more about that, about practically what could IUSSP members and demographers contribute here to this, to build on some of the work that Everton and colleagues have done. But let's go very, very quickly, maybe like a minute and a half before we move over to Montasa. Everton, Bernardo, Andres, over to you.
Well, about migration, another point that I need to mention is that we don't have administrative records for migration. And Brazil, it's rely on census. So it's always a delay. If you wanted to do this kind of analysis, especially taking into account population at risk, and then for sure we needed to have another tools. What Andres suggests about phone and Facebook data and Twitter. I think, as far as I know, Bernardo can say something more. We didn't have much of this kind of information. That was one attempt to, before, by law, to have the phone monitored of the people. But I think the president just shut it down because he said, yeah, it's a law of privacy, we cannot. So there was this kind of things that there was kind of setbacks that didn't push to have this kind of data available. But that was one attempt that we have done. I don't know about the other countries. I don't know if Bernardo wants to say something more.
In the case of Brazil, IBGE did the PNAD COVID, is the household survey, and they did a special issue on COVID. They didn't ask questions on household mortality or anything, but there's a lot of questions on labor market and health issues. So if people felt some symptoms that could be related to COVID, I'm not sure about migration questions, but this could be a possibility. Like, well, it would be hard to relate it to the mortality, but we could see if people move from. But I don't know the details of the questionnaire. I know that they have a lot of questions on labor market and the cash transfers that was implemented. And there was a long health-related questionnaire, but yeah. But then Stefan led this paper with trying to making the case for the importance of adding the household deaths and on the mobile phone surveys that people could use to track COVID, and then with the other questions that they already asked, then we could get some better idea of what is going on.
Great, thanks so much, Bernardo. We're right on time here, so let's close out the moderated Q&A and thank everybody for engaging in the Q&A. and then pass to Montasa Kamal from the International Development Research Center in Canada for some closing remarks. And just as we do that, I just want to remind colleagues that after the webinar, you'll receive an automated email from the IUSSP Secretariat, a little survey to let us know about how the webinar went. And please do get in touch with the IUSSP Secretariat if you have specific suggestions about topics or speakers that you'd like the IUSSP to sponsor in this webinar series. I think there's a lot of interest and a lot of openness to do more of this. On that note, please, Montasa, thanks for being with us today, and over to you for some closing remarks.
Thank you very much, Romesh, and thank you very much for the panelists and the discussants and the participants for the very interesting questions and presentations. I'll be very brief because I know we're over time already, but I just want to say it really was a very inspiring and a very important and timely webinar. The pandemic shows us the importance of reliable permanent civil registration systems that are able to produce disaggregated comparable data at the lowest level of administration by age, sex, and geography. And the paper today showed, and the presentation today also showed us that how important the level of analysis is for this work and for decision making. So most countries, as you all know, started with the registration of deaths for in big cities or big centers, but as the analysis clearly shows a significant increase in the paper today, the analysis shows a significant increase in deaths, sometimes up to 200% in inland or faraway areas, which are normally underserved in terms of health services and maybe even more obstacles in terms of registration, civil registration, even under the best of circumstances. So this is hugely important angle, not only for Latin America, but globally, because traditionally those populations in those areas are neglected and underserved. There are also areas where the obstacles to civil registration are greatest, and I think this is where this analysis would be very helpful to understand what are those barriers from the demand side on those different locations. And I think hopefully some of the comments from the audience brought this to attention. So I think it would be good to pay a closer look to it. This is pioneering analysis, and we should really build on it. The presentation also today, or the webinar today, really brought also to mind questions about what are the best data sources, what is the baseline, what is the quality of the data and the timing of the data itself to calculate excess mortality, and why this is important. It also brought to mind the questions about is the cause of death, sort of calculating excess death, is this the only way we can reach those good numbers, or are there other ways to, in addition to calculating causes of death, excess death, to also triangulate with other sources of information? So the interaction or the interconnectedness between this type of data, or this approach to calculating excess death and other approaches, would be also important to explore, I think, in the future. But I think we are at a really good launching pad for this. And also the presentation today, we heard about sort of the need for a more sophisticated modeling. And I would add to this the need to have an approach where this can be, the different approaches can speak to each other. And the importance of this is not only for sort of pure scientific benefits, but it's also for decision making. Usually, and as we know, in the case of pandemic, in many societies, some are doing better than others, but including in Latin America. But the reality is decision making and decision makers can't always wait. They are in a situation where decisions have to be made. Sometimes, even with the best of intentions, those decisions are, in retrospect, appear to be ill-informed. So how can we work with data faster? What are the possibilities to record, compile, and analyze the data in as close to real time as possible? And how do we support building resilient CRVS systems that can respond to crises and emergencies, even in situations some other debilitating factors. The apparent politicization of the response to COVID has been witnessed in many places, and it shows the intricate link between governance and health, and between health governance and public health. CRVS professionals have now a window of opportunity to build the case of how essential CRVS systems are for pandemic responses, and many of the CRVS professionals have heeded this call and are trying to make this case. This is an opportunity for us to demonstrate why it is in the best interest of governments and people alike to seize the opportunity to rebuild better during the post-COVID period, better CRVS systems during the post-COVID period. I will end with just a sincere thanks and huge thanks for the panelists, discussions, and the very engaged audience with the very interesting questions, and also appreciation for our partnership with IUSSP and Romesh for organizing this panel. I invite you join in what was mentioned earlier. Please visit our websites for IUSSP and for the Center of Excellence for Civil Registration Vital Statistics Systems for additional information and resources, and to know more about our other activities. Thank you very much, and have a good rest of the day.
Excellent. Thanks so much, Montasa. Yeah, I think you summed it up very well in terms of what we're talking about here is really the need for decision-making under uncertainty. And I think, you know, Everton, Bernardo, and Andres's work really shows us some of the tools of demography and the power of death registration systems and other data systems to really unpack questions around completeness and quality, and grapple with how to inform the response, even though the systems and the data are clearly not perfect. With that, I really do want to echo Montasa and thank Everton, Bernardo, and Andres for sharing this work. It's enormously helpful and very rich for us all to engage. And a special shout out to Jenny Garcia and Stefan Erlanger for the discussant comments and providing additional reflections. And of course, to all of our participants online, both for the questions, the comments, and your participation today. We look forward to hosting some follow-up to this event in the near future. Thank you, and wish everybody a very pleasant rest of the day or evening, wherever you are.
Thanks everyone. Thanks so much for the opportunity to present. Bye.
Thank you, bye-bye.
Bye.